It's an honor to be here. I've already learned a lot, so hopefully I can give back and teach you guys something here. So is this the...
Yeah, forward.
Forward, okay, perfect. Well, Jeff wanted me to talk about robotics, and it's something that I'm super interested in. I like machines, and I like tools, and I like meshing those things together, and I like doing spine surgery. So that's what made me want to talk about this. So the three things, kind of the three areas of that are, we wanted to talk about what's the benefits of pre-planning, how does that help you intraoperatively, and how does this reduce OR time, and then does this improve outcomes? All right, so we'll try to move through this because I know I'm standing between everybody and lunch, so that's the next thing coming up. So I like to think about it like Lowe said, like, what's the problem that we're trying to solve? Like, if we're trying to solve how to get that screw into the vertebral body, which is basically like putting a wood screw in a piece of bone, how do we use a computer to do that? So a machine would sit right in between that computer and that screw, kind of like the caveman that Larry was talking about earlier, banging on that rock. Like, how do we make it so we're not a caveman, and how do we make it so we're taking care of ourselves ergonomically, not standing on our heads, not upside down, and make this easy for us so it's therefore easier for the patient. So I copied this from a review article. I thought it was kind of interesting to kind of start off with, because their quote was, the major difference between navigation and robotic platforms is that robotics requires us to pre-plan for the screw trajectories, which means that in navigation, we just put it in and we see where we're putting it. We don't have to plan where we put it. And proponents of robotics believe that this preoperative screw planning is going to help us. It's going to make us understand the anatomy. And there's another group that says, man, I don't need that. Obviously, I'm in the first category there. So what is a robot? Like, I think this is a funny article. I copied this out. I mean, people don't really understand what a robot is. I mean, are they going to take our jobs? Or are they not? So I like this quote here. We define a robot as a technology that takes a machine and replaces maybe something that we do. It's hard to kind of give that up. Like, it's something we learned earlier, that maybe as a surgeon, we don't want to give this up. We do everything ourselves. We're not going to give this up. I asked one of my total joint colleagues before I came down here, I said, are you using the robot? He's like, I'm not letting that robot do my surgery. So I think it's, these are the jobs that they listed that robots are going to replace. Actually, doctors was on the list. I think they're a little bit confused, because I do think Watson is going to help us, and I do think surgical robots are going to help us. I don't think they're going to replace us. So I think that's kind of fake news that we're going to be replaced. So what's the purpose of me talking about this today? How do we look at imaging, navigation, and robotics? How do we decide if that's going to help us do surgery and help patient outcomes? I like the INR analogy. Everybody's heard of INR. So imaging, navigation, and robotics is kind of a sequence there that helps us think through this. So, we're going to talk about what are the problems. Like I said, I like to lay out the problems. What's the issues that we're trying to solve? We're going to look at some of the technology and some of the literature and try to come to a conclusion at the end. Spine surgery, like we heard earlier, is certainly going up. This is a little bit old data, I guess, but it's super expensive, and the number of fusions is going up. I will say, though, that my fear of somebody taking away a one-level T-lift is not super high. I mean, maybe the cost, my reimbursement will go down, but I think there's certainly a lot of room on this $100,000 area to cut costs versus taking our cost away. Because a one-level T-lift is such a fabulous operation for somebody who needs it. It's just a wonderful, it's a wonderful thing. So we've got screws to go back to the problem, we got screws in the lumbar spine, T-spine, and sometimes in the neck up there too. So what is imaging? Everybody knows what imaging is. Navigation is, this is the second compass that we've seen today, so I thought that was kind of funny. The compass tells us which way we're pointing, but we have to mesh that with the map. And so there's two things that have to be navigated: our own the surgeon has to know where he is and know where his instruments are, but also the robot actually has to know where itself is as well. So the robot has its own internal navigation system to itself. And so a robot, we think of a robot as like an arm like this. And so intuitively, to me, it makes sense that obviously when you're building a car or building a machine or putting a screw in, the robot is just inherently going to be more accurate than a human. That's just my feeling to kind of go into, it's like a thought experiment, like since we already saw a picture of a black hole as well today. Einstein kind of figured out his theory of relativity by doing thought experiments. So just to me, it makes inherent sense that the machine is going to know better if I pre-plan where to screw. It's going to put it in there every time in the same place. Makes my job easier that I don't have to worry about where I'm putting the screw. So we've got, all the implants. Basically, we've come down to pedicle screws. And then we've got the workflow kind of comes into two workflows. Mostly what we're talking about today is 1 or 2 level MIST lifts. Longer fusions with a lot of implants is certainly a different workflow. These are just a couple cases. That's a long fusion. There's a coronal deformity. This is a 2 level MIST lift. I like the expandable cages. I haven't used these 2 planar expandable cages, so I'm certainly going to look into that. I like to see things, so this is the way I do a MIST lift. I make my incision horizontally because I think the scar heals better, and then also I can make it a little bit longer, and so I like to see the nerve root. I like to see the disc space. I can decompress bilaterally. The interspinous ligament is underneath that medial retractor. The spinous process is there, and this is angled all the way under, so I can easily see across to the contralateral side. And so then I can do a 2-level T-lift through those two incisions there. So, that's kind of a boring slide. Surgical navigation basically is optical. Like for the surgeon to know where he is, there's some type of eye in the sky that tells us where we are, that's attached to the instrument. So the robot has to know where itself is as well. And so a robot, actually, most of them they can have an optical sensor on the end of the robot, but the robot also knows where itself is because it has six motors that tell that there's 6 degrees of freedom for every place in space you can get there with 6 degrees of freedom. So the robot knows, it gets there because it knows where it's going, and it senses each of those motors knows where it is. So in a way, like this is the same type of machine as the one we just saw. It's a 6 degree, those six longitudinal actuators will put the top of that in whatever position that you want it to be. But we don't really think of that as a robot, but it's really the same type of machine. So what is a robot anyway? Google, Siri is a kind of a form of a robot, industrial robots. Surgical robots, I think it helps to think of them in 3 categories. What the names of them are is not, I don't think is certainly agreed upon by everyone, but a telerobot is more like a drone type robot, which is like what the general surgeons use. A Da Vinci robot is that type of robot. And so it's not doing anything autonomously. It's directly controlled by the surgeon. And then there are robots that are completely autonomous. I don't have any experience with those, but that would be something that actually you program to do the surgery and you press a button and let it go. So I think there's a total knee robot that does that, but I'm not familiar with that. The ones that we have experience with in spine are what could be called assistive robots, meaning they assist us to do the surgery, they help us know where we are, and they show us how to do the surgery. And it's a similar for there is a assistive robot for doing a knee as well. So I think trying to think of those categories is helpful. So that's the Da Vinci robot, and the surgeon is controlling the actions of the robot directly. He can be in the same room, but he could be somewhere else. I don't think it's going to be too popular for having surgeons to be in a different room than where the patient is. But in certain areas, like in Alaska, people are thinking about doing that. This on the right is a computer-controlled arm, and it's going to help us guide the placement of where the screw is. So this is just imaging, MRI, CT scanner. Navigation is really optical. There's different ways to do optical navigation. So there's several commercially available robots. We're not specifically talking about each of them. So I think once you get down to deciding whether you need a robot or how to do it, I mean, the person that's buying it is really the CEO or somebody associated with the hospital or surgery center. So it places us in an unusual situation. And this was a quote. This is the first quote from the abstract of this paper here. Surgeons and hospital administrators may lack sufficient information to compare options and make purchasing decisions. So they gave a list here, and I think it's a pretty reasonable list. Open platform navigation allows you to use different implants with the same, I mean, you can use different vendors with your robot. I'm not sure what number 2, what they're referring to here is, but having different, having different ways to do navigation would certainly be helpful. I'm going to go back to that. I mean, there's different CT scans, there's 3D fluoroscopy, there's a variety of ways to gather the three-dimensional data. I think radiation safety is something that's underutilized as we start using these CT scans. I think it's important to track that, and our radiation colleagues are certainly available for that. I've gotten a memo from the hospital. If you do a really long construct, you can actually get quite a lot of radiation exposure from the O-arm. So how do we determine if a robot is cost effective or not? I think that's a difficult thing to determine. This was a paper that tried to tabulate that by saying we did this many cases. If we use the robot, it would convert, so many of those would be converted to MIS cases, which would therefore decrease our infection rate and decrease our revision rate. So they calculated that to be an annual savings of $608,000, $608,546. I mean, I think I would have to go back and get my business degree to kind of understand how to make these purchasing decisions. But again, to me, it all goes back to this is going to make it more easy. I mean, it's going to make it easier on the surgeon. It's going to be more accurate. So therefore, it's eventually that's the most important thing to me. So robotic development, I mean, we started this, it's been growing over the last 15 or 20 years. This is the case. This is a single level T-lift case, just shows the robot. This part of the robot is autonomously moving, and it shows you program it where you want it to go, and then you pass a drill and a guide wire through that actuator. I find it very easy to set this up, and I find it very efficient. So there's different ways. I'll just put, while I have this picture up here, that retractor is very important to get that position so the soft tissue does not push up against the robot. Like that's where you get into trouble, is when the soft tissue pushes against the robot. And there's usually a person there that's administering the machine, and they are exceedingly meticulous about noticing that. Like, if you really have to follow the steps to make this work correctly. You can't cut any corners. So that's trajectory assisted. That particular robot does not have optical navigation built in. There's now a way that same robot has optical navigation built in. Currently, my experience is with the earlier generation. It really doesn't change very much having that navigation on the drill, in my opinion. I like having navigation because it helps us know where you are, and it helps you do your disc prep appropriately, having the navigation there. This is another, the Dr. Nicholas Theodore has designed one of the robots. I think it's interesting to understand the way these things are designed. So there's several different robots out there, and this just kind of tells you, this is from one of their publicity things. People are very interested. It's like we heard earlier, do you do MIS surgery? Well, who's going to say no? Pretty soon, I think, people are going to be saying, do you do robotic surgery? And, we're going to be saying yes. No one's going to be saying no. So this is just another picture of another version of the robot, but really they're very similar concepts. It's an arm with a image-guided, you can use image-guided tools, but let me go back to that other one here. If you look here, what I think, does this have a pointer, Jeff?
The top one, top button.
Oh, there we go. This right here is why I like to have the navigation here, is this probe helps you know where you are in the disk space, helps you know how much facet you've taken off, and so that is why I like having robotics and navigation at the same time.
Bob, could you expand on that? So you said that you like to have navigation and it helps you with the disk prep, right?
Yes.
So are there instruments that allow you to have navigatable like disk preparation?
Well, I suppose you could have the curettes. I mean, we use the curettes to prepare the disk space, but this probe right here has just a tip on it, and you can tell, are you all the way across? Are you in the front? Are you up in the back? And where are you on this side?
In the disk space.
In the disk space. So that probe is how I know that I've covered, we think of it as like a circle on the side like this. And so we probe around there, and that probe helps us know that we've prepared all the end plate and removed all the disks. So that's what I think navigation is very helpful for. Whether or not you have the drill navigated while you're placing the screw in with the robot there is a little bit kind of belt and suspenders. It doesn't really change anything. To me, having the navigation is more for helping know where you are when you're doing the decompression and the disk prep. And that's why, one of the robots, they never added that in for a while, but surgeons are very uncomfortable using a drill and not knowing where it's going. They like to be able to see where it's going. In a way, like I would kind of joke around with the robot, because if you don't have the drill navigated and you're just following a percutaneous track and you don't have fluoro in there, it doesn't even matter if your eyes are open or not. The drill is not, you have no visual feedback of where the drill is, and surgeons are uncomfortable with that. So all the systems are adding, nobody likes that, so they're adding that in. There's the total knee robot is actually, they do use the robot arm to remove bone, and it has like a tactile sensation where you're driving the burr, but whenever you get up next to where you don't want to remove bone, it won't let you go past that. It's really an amazing device. I think we're going to end up down the road using the burr, our burr that we use for our laminectomies is going to be attached to navigation. So you're going to be able to kind of know exactly what part of the lamina you're taking off and what part you're leaving, because that's important if you're trying to preserve stability. If you're doing a fusion, I like to take off as much lamina as I can, but
That's the makeup?
yes.
Is that true for all the total joint robots? Do they have that depth?
Well, this is really the only one that I know of that is in widespread use. But yes, it has an arm, and when you're using the burr, it won't let you go too far in or too far out. I mean, you're still doing it, but it's basically like you draw out the part of the bone that you want to remove, and then you just use your hand to remove it. So it is a little bit like my colleague said, it's like you're kind of you're turning some of this work over to the robot. And so that's hard for surgeons to accept. It's hard to understand because, like we also alluded to, we like our jobs, we have our routine, we don't want to change anything. Nobody wants to do anything different. So letting something else tell you where to put your hands in surgery is a little hard to get used to. So, I mean, the business guys are very interested in this. I took out the list there. That's why that's in italics. The business guys are all trying to figure out which company to invest in, which robot's going to be popular, because the people who follow these stocks, it matters. If you sell a lot of robots, your stock's going to go up. So the clinical evidence, these papers are from the one that's been around the longest, and basically the papers revolve around how accurate the screws are, as well as trying to gauge when you change, did you improve length of stay or outcomes. So I think it's kind of interesting, accuracy of implants. When you use a robot, it's about 1 millimeter accurate. It may be less, maybe 0.5 millimeter, maybe 2 millimeters, but that's about the level of accuracy that you need. Interestingly, you can go to Amazon and get something that's accurate to 1,000th of a millimeter for $39. So, or we can pay $1 million for one that's accurate to 1 millimeter. So this is just a graph showing, it's hard to see this really. Percent reduction in I do think the robot decreases radiation because you're not using all the you're not using nearly as much fluoro live. You take a couple of fluoro shots, but then everything is, there is no fluoro in the surgery except at the end. And I do like to, when I put the cage in, I bring the fluoro back in so I can see exactly where I can see the cage expand. You can navigate the cages in, but you can't see them expand and what the bone's doing. So there's been a couple of new case series. And basically the category of these is they report, it reports out, I've done this many cases, and these, the reported accuracy is about 97 to 99%, where previously the pedicle screw accuracy is more around the 90% accuracy. So, I think a 5 to 7, to 10% increase in accuracy for pedicle screws, I think that's a big deal. I don't exactly know how to quantify the cost of that, but this is just another study that's showing the case series, CT findings 97% accurate. That's an older one. This paper, this is a company paper, but I think it's pretty clear, like this data to me is fairly compelling that the robot is more accurate than the surgeon putting them in. So we recognize some of these authors. They came up, they went to Cadaver Lab. It was basically like a show-off, a showdown between the surgeons and the robot to see who was more accurate and who was faster. And they did MIS cases and they did open cases with those surgeons. And so operative time, pretty comparable. Not much different between the conventional surgeons and the open technique. They were a little faster than the robot, a little slower on the MIS technique. And they graded it. They did CT scans and checked where all the screws were, and they graded them in these 4 categories, within 0 to 2 millimeters of where you wanted them, 2 to 4, 4 to 6, and greater than 6. So the data shows that in the robotic technique, all of them were 0. And in the conventional, which just means regular surgeon doing that, all of them had, however you want to describe it, screws that aren't where you wanted them to go. So to me, this is just a series of surgeons. How to track this data, to me, that's kind of a compelling slide, is the robot's more accurate than the person. And like I said, that doesn't seem that surprising to me. So how do you learn to use the robot? The learning curve for the robot is really a technical situation. Once you understand how to set it up and apply it to the patient, there really is no learning curve. Once you've done it once, it does the same thing every time. And that's what these folks showed, is they did 80 patients and they said there's really no difference in the first 10 and the second 10, which is contrary to MIS, doing an MIS surgery, a T-lift through a small hole. There's definitely a learning curve for that. Like that is, now sometimes when I do an open T-lift that's a revision or something like that and I have a big incision, I'm like, oh my gosh, this is so much easier than doing it through a smaller hole. And so the learning curve for a robot is pretty low. I think we're here. I don't know. The industry. It's going to be interesting to see how these companies are adapted and how they're, how these robots continue to be sold and developed over time. I think the ergonomics of the surgeon is important. I think we need to take care of ourselves. This was just really a different type of thing, but a lot of surgeons complain about pain and, you're standing on your head and this, that, and the other. So I think the ergonomics of the surgeon is important. There was a couple of reviews of the literature that have come out recently that are all kind of pointing towards the fact that this technology is more accurate. Whether or not it improves length of stay and how it relates to that is not 100% proven right now, but I think this summarizes my position on it. It's definitely more accurate. It has a short learning curve, pretty low complication rate, and it may reduce fluoroscopy and length of hospital stay. So those are my conclusions. Thanks, Jeff.
Thanks, Bob. Great talk. Questions from the audience? Okay, I have one. So right now, the robotic platforms essentially, they function as guides to place in pedicle screws,
yes.
Right? So they help us with trajectory.
Yes.
But currently, there's no way for us to do like rod insertion or rod bending, and or even decompressions, right? So how do you see that all evolving, and when will these things allow us to do an end-to-end, skin-to-skin robotic surgery?
Well, I think I don't know how long it's going to take before we allow the burr to be attached to a robot like they do in joints. I think the accuracy needs to be higher for spine than joints. As someone alluded to, like we're playing around with the dura. So, it has to be pretty accurate. And so I don't know. I think it might be longer than we think. I think rod bending is going to be a little bit more automated, and you could think of that as a separate machine that's going to program your rod that you've pre-planned out. And I think rod bending is pretty close, but having them kind of in a way take over the surgeon doing the procedure, I think is pretty far out. But I think having them help us place the screws in an easier fashion is here. So
it's interesting because the Da Vinci platform really, it's popularized in the abdominal and pelvic surgeries. And it's really that telesurgery, right? When you're literally, the surgeon's sitting like right next to the patient, but not even scrubbed in, and they're controlling the robot. And then you talked about like there's currently what the robots are doing is assisting us.
Right.
They're assistive, but they're not autonomous just yet, right?
Yes.
So do you foresee a future where it will become autonomous?
I mean, it's certainly possible. I think it's a little bit down. I'm not that. In a way, I might say I'm not that worried about it because I don't want to lose my job to the robot. But it's certainly possible. But like the cars and the robots, they do sometimes crash, and you need a person there, in my opinion, to keep an eye on it.
I agree with you on that, but I think maybe even a more accurate analogy would be, how about robotics in like the industry, right? Like what's happened in the automotive industry. You don't hardly ever see, because let's just be honest here, like even 20 years ago, you used to have people on an assembly line,
right? Human
beings putting together a product that's manufactured, right? And now it's all being automated, where if you could argue, right, regardless of whether it's total joint surgery or spine surgery, that we could automate it. Do you know what I'm saying? So meaning that, like, I've played around with Makoplasty before, and it's pretty amazing. Like, so what you do is you plan it out, and it's similar to how you plan out a screw, but you plan out how much bone you want to take and how much bone you don't want to take, right? So that when you actually use that burr or that drill, it will not allow you to get beyond those borders, right? So essentially, I know where this is going.
Yeah, I agree with you on that.
What's going to end up happening is we're going to plan it out. We're going to have the MRI and CT scan. We're going to say, I want this part of the lamina to be gone. I want this part of the frame, and I want to do this much foraminotomy. And then we're going to take a burr, and it's going to only allow us to do that much burring.
Yeah,
right?
I think that's pretty close. You have to ask the manufacturers how close it is. I hope it's. I mean, that I think is close. Yes.
I mean, but from my standpoint, I think that, again, we need to be in front of it, and guys like you and I who believe in the technology.
Yes.
So, like, it's important for us to make sure that we as surgeons get ahead of it, because ultimately, like, if you don't want to be out of a job, at the very least, you'll be like the manager of these robots, right? Because no human being will ever allow, a robot today to do the surgery just autonomously right now. But at the end of the day, I mean, if you think about it, like 20 years ago, do you think people would have ever said, would you ever drive a car that was fully built by a robot? We would have said, hell no, there's no way. But now it's like, we don't even think twice about it, right? So what I'm saying is that right now, currently, we have the capability. The technology exists. It really does. We could easily apply that technology. But I think what it is like surgeons are not ready for it yet, and
Right.
patients are not ready for it yet. But ultimately, if the technology exists and you show compelling data that the robots are 100% accurate, whereas we're like maybe 80 or 90% accurate, that's pretty compelling.
Thanks, Jeff.
All right. Thanks a lot, everybody.